This is the second in a series of 4 presentations by Gabby Flores, who we met through a colleague who knew her. She's in Kansas City, so we didn't really just run across her at the local agency. And we're really pleased to have her do some training for our staff and felt it was so good. We would like to share it more broadly. This one, of course, is about cultural humility. Humidity. We don't have any humidity today. Hopefully we have some humility today. Gabby brings a very strong background. She's been in healthcare. She brings social care excellence. She's currently Associate Vice Chancellor of Diversity, Equity, and Inclusion at Metropolitan Community College in Kansas. She has a beautiful way of teaching, and she's going to really walk us through cultural humility in its many forms and where it comes from, how it influences, and what we can do about it. So I want to also welcome other guests from GSWEC, our current faculty and students, and from Pacific Clinics, whose staff were also privileged to join us at their preference. So no further ado, I'm really delighted to present Gabby Flores, and the floor is yours, Gabby. Thank you for joining us.
Thanks very much, June, for the warm welcome and really kind remarks. I so appreciate it. And I've really enjoyed working remotely on the West Coast. I wish I was there today because we had snow over the last few days, and I was in Chicago and there was a blizzard. So I'm mentally with you guys in California today. So I'm really excited that Partners in Care and GSWEC have partnered with me to deliver this series. So excited for our conversation around cultural humility. I won't go into a lot of detail. June introduced me. My day job is Associate Vice Chancellor at an area community college here in Kansas City. But I have 20, so while I'm currently in higher ed, I spent the last 20 years in healthcare systems, 2 different hospitals, and then working very specifically on language access with refugee and immigrant communities here in Kansas City. And I'm kind of an accidental healthcare worker, so I was trained in cultural anthropology and then healthcare administration and management. So I'm kind of the island of misfit toys is kind of where I fit in. And then I had the privilege of founding my own small business during the summer of 2020, as many other entrepreneurs did during COVID with idle time. I identify as bilingual and bicultural, and so I bring that perspective to these conversations. And I've also been trained by the Cross-Cultural Healthcare Program in Seattle, Washington. So just a little bit of context about me. Before we get started, I really just wanted to kind of lay some scaffolding for our conversation, whether today is your first or if this is you're here as part 2. I just want us to kind of have a sense that today's topic around cultural humility might stir up emotion or feelings, might cause some triggering, even though we don't have an open conversation. This is a webinar format. So, we're still going to be alert to the chat and to the Q&A sections. But sometimes, we really need to engage or dig a little bit deeper. We ask and invite you to just be as present as you can. I know that social workers get pulled in multiple different directions all the time. And so many of you might be multitasking, but do your best to just kind of reflect and be engaged if you can. Think about today's topic of cultural humility, both from a personal and professional level, but also institutionally with a systems lens. And I know that is inherent in social work training, and so it won't be a far stretch for you. And then we won't go through all of these, but I really like the last one. Really kind of being in a both and mindset is really important. Holding that tension between, you know, things can be one way and another way at the same time. It's not always either or. And so sometimes as we explore challenging topics that can be very subjective and influenced by how we were raised or the social demographic that we come from. Sometimes it can be hard for us to acknowledge that someone else's experiences were different than mine, but are just as valid. So just kind of hopefully you can agree to come along this journey with us with these community agreements. If you've got any questions, please go ahead and post those in the Q&A box. And I'm not sure if the chat is on. That's one thing we forgot to check before we did our tech check first. So please, if someone can be on the lookout for the Q&A if things
I'll
come in.
check that.
Great, thank you so much.
I've got
Appreciate
them too.
it.
We'll watch.
Thanks so much. So today, with our short 50 minutes that we have, this is what we're going to cover. We're going to talk about cultural humility and how it might relate to trauma and toxic stress. We'll describe how unconscious bias might affect the healing relationship between patients, families, and providers, whether it's a social work provider or interacting with the healthcare system. We'll identify how cultural humility and trauma-informed approach can reduce health disparities and improve health outcomes. And then we'll lastly describe the skills necessary to navigate better in cross-cultural settings using a very quick 5-step model. So we've got a lot to accomplish in this next chunk of time, but I think that we will have a really robust conversation. And again, just kind of to keep adding to the scaffolding and the context of our conversation, I think it's important for us to reflect on our why, especially at this table of social work practitioners. Many of us came into this space. I'm a social work wannabe. Probably if I had to do it all over again, I would have gone the social work path if I had known it was so rich. But I've been trained and taught by many social workers over these decades. And I think it's important to think about why we do the work that we do and how we get connected and how we serve our community, how we serve our patients and families. And so if you haven't seen this video, I think it's just a really good grounding video that helps remind us why we're in social services, why we're in healthcare, why we're out here supporting communities so that they can live better, more fulfilling lives. So as some additional context or thinking around, empathy and walking in someone else's shoes, the other part of our conversation is really about equitable care and how do we ensure that all patients and families can receive the highest quality of care in order to have the best outcomes. I really love this graphic. It was done by Robert Wood Johnson Foundation. It really helps us better understand that we need to kind of migrate our mindset from an equality space where you give everybody the same size bike, but not everybody can effectively utilize the bike. Some people will be really uncomfortable and some can't access it at all. But if we shift and go to an equity mindset, it's really about getting patients and families the right set of resources, the right tools, the right clinical care to have great outcomes, to have great healthcare results long term. And so in the bottom, you can see that when we get the resources fit right to each individual, which takes a little bit more time and a little bit more patience, we have greater outcomes long term. Before we really kind of dig into defining and discussing cultural humility, I thought it'd be really helpful to just spend a minute talking about what humility is defined as. So just kind of from the definitions, from the dictionaries, Merriam-Webster defines it as freedom from pride or arrogance. Cambridge describes it as the feeling or attitude that you have no special importance that makes you better than others. So as we begin to talk about cultural humility, please just kind of keep hanging on to these definitions, because I think you'll see that the model that we'll explore is grounded in these two concepts. This is a trauma-informed practice framework that I borrowed from a colleague, Patty Davis, who specializes in trauma-informed care in a pediatric setting. And I know you guys are very much embedded in the geriatric setting, but the framework applies across the age spectrum, in my opinion. It's really centered in cultural humility, which is defined in this conversation as cultural humility allows us to be open and explore the experiences, beliefs, attitudes, concerns, expectations, and preferences unique to each person we encounter in the work setting, as well as our personal lives. And so you can see here that this trauma-informed practice framework is grounded in cultural humility, and we'll unpack the center bubble a little bit further. But it's got pillars in concepts of safety, choice, trustworthiness, collaboration, and empowerment. The trauma-informed approach is really critical. Again, we know that adverse childhood events, which are events that impact child development, have lifelong effects and can have impacts on health outcomes as adults and as seniors. That children are especially vulnerable to the effects of trauma and toxic stress. And we know that cumulative toxic stress as you grow and develop from a child into an adult can have huge physical ramifications. And then the impact of trauma and toxic stress can really affect people's approach to accessing healthcare services, trust and rapport that they might have with their healthcare provider, including those kind of in that social services sphere, trust being a huge important piece to that. We know that prolonged exposure to toxic stress can be really detrimental physically because of stress hormones impact on the body long term. So we know research tells us that toxic stress can have an impact on blood pressure, blood sugar, and more recently we know that they're trying to draw correlations between kind of a low-grade toxic stress and increased maternal morbidity and mortality. So there are some studies happening currently that are linking toxic stress, especially in African-American Black moms and babies. Another fantastic reference resource is Melanie Turvalon is the what I would call the grandmother of cross-cultural nursing and cultural humility. This is her definition of cultural humility, that it's really an approach to reduce our own biases in order to help reduce healthcare disparities and inequities. So by tackling our own bias that we might bring to every care encounter, by working on that kind of personally, long term, it'll have a huge impact on patient care delivery. The other notion or concept around cultural humility, which has kind of been a reframing that's happened over this last decade or 15 years or so, is that previously you'll hear cultural competency as the terminology that's very common. This cultural humility framework really allows us to think about it as a journey, right? Competence implies an end game, that you arrive at some endpoint, you've completed that last box on your checklist, and now you're deemed competent. With this cultural humility mindset, it's really about lifelong learning and process improvement, if you will, across both personally, professionally, and then looking at your systems. And so we'll dig into this a little bit deeper. It's also about perspective taking. So really, when you pause, and I'm going to reflect back to our community agreements, when you think about both and thinking mindset, it's really about perspective taking. I experienced X growing up, and you might have experienced Y growing up. And how do we learn from each other? And how do we validate each other's experiences along the way? So this is just a little bit of additional reference. Here is a really wonderful, I need to give a disclaimer. It's a little dated. It's for the Institute for Healthcare Improvement. It's a little dated in its format and audio, but the message is really spot on about how we think about cultural humility from a personal and professional level, but how do we integrate it philosophically into our clinical care delivery models and our systems and the structures within which we have to operate.
We've switched over time to the terms cultural humility. I think depends on how you view the definition. And so it's more about creating the attitude and creating the interest and curiosity. And it's when we talk about cross-cultural care, it's the culture that we come from and the cultures our patients come from, in a true partnership. And so I think that's how we're framing it. And that's why we've moved to the term humility, whereas competence seems like it might be an endpoint, and humility is more of an attitude. I think for an organization to start would be to reach out to your community, and again, what's most important to the community when it comes to healthcare. I mean, patients spend 99.5% of their time outside the doctor's office, and we need to take the care to where the patients are, what's most meaningful for them in their community, whether that be at work, whether that be in the neighborhood, whether that be in their faith-based organization. And so I think that's an opportunity to identify those communities in the neighborhoods that we serve and start having a conversation. All care is local, all care is relationship based, and even just saying, you know, I don't know, help me understand what's most important to you, what's most important to your family. Maybe say for diabetes care, what do you want to work on? Not what are my goals for you, but what are your goals for yourself, and here's what's recommended. So I can come and have a discussion with, based on what your symptoms are, based on your conditions, here's the recommended care. Now, how do we have a discussion on what's important to you, and how can I help support you? I mean, even for the past, I've been in practice now for 20 years. I mean, I've learned so much from my patients that I didn't know when I first went into medicine. And as we become more diverse as a community, I continue to learn more things. And so I think from that standpoint, it gives us the joy in practice to be able to really learn from our patients, as well as share with our patients what we've learned over the years.
All right, so before we move forward, I just wanted to do a quick check and pause and make sure there's no questions before we keep moving forward to kind of talk more about cultural humility application? Any chat or questions?
Yeah,
Maybe-
none so far, but I'll continue to monitor.
Okay. Maybe somebody could just drop a test message in to make sure that it's working correctly, just so that I'm a little skeptical of technology. Oh, I
Thank you,
see.
Marjorie. Yeah, we
Thanks,
got a
Marjorie. I
test.
appreciate it. Thank you so much. We'll just keep on going because of time. I want to now just kind of transition us a little bit to talk a little bit about application of cultural humility, both kind of at that professional, personal level, but also institutionally. Again, this is borrowed from Melanie Turvalon and Dr. Marie Garcia. And it's really a very kind of simple approach, really thinking about our own individual cultural self-awareness and our lifelong learning and commitment, and really taking a critical look at our own biases and where we might have our own blind spots. So that would really be kind of at that kind of basic personal level, really looking at an institutional level and thinking about the patient-provider relationship, whether that's sometimes you as a social worker might be an intermediary in those conversations, but ultimately the relationship between patient and the healthcare provider can sometimes be imbalanced because of power. And we'll explore this a little bit further, but that's something we need to kind of help control for or level out a little bit. And then applications of cultural humility from an institutional accountability perspective. And I think the physician in the last video spoke to this a little bit more. How do we partner more effectively with families and communities at an institutional level for both advocacy, collaboration, problem solving, and what I would call co-creating solutions for those problems? And so this is just a really simple kind of application matrix that we'll walk through. From a personal perspective, just really thinking about these following items, really kind of having an open mind to learning, especially when things can be uncomfortable or difficult. And I think that last physician shared that she's been in practice for 20 years and she has learned so much from her patients, kind of from that cross-cultural perspective. And it doesn't have to be foreignness, but just someone who may have grown up in a different, with different experiences. Sometimes really keeping in mind that our healthcare systems don't always have the answers. And sometimes we have to really lean on the expertise of our patients and families because they're the experts in their symptoms, they're the experts in their psychosocial challenges. And we are there to just help provide supports and listen in some cases. Really being comfortable with your own abilities and limitations, and flexing and learning how to create new muscles in spaces that might not be comfortable. And then taking the time to really think about where your blind spots might be and working to overcome them. And at the end, we'll share some resources of some additional tools and learning you can think through. This concept of balancing power and addressing racism and bias, kind of thinking as that intermediary step between kind of self-awareness and institutional change, really valuing the patient-provider partnership and also the partnership with the institution and community. Recognizing that privilege and addressing the impact of historical trauma and oppression, this can be a really challenging, both kind of at a professional level, but at an institutional level. And there's a lot of examples out there. I'm going to just share one that comes to top of mind. I can't remember what hospital setting it was in, but there was a movement several years ago to pull down the wall of founders at various hospitals across the country, just in the same way that you might pull down a statue of a Confederate supporter. Many of our founding fathers, if you will, of many of the larger hospital systems, there was no acknowledgement of some of our other marginalized communities that helped contribute to the founding of those institutions. So that's just one example of that. Acknowledging and addressing our own internal biases. Again, this is that intersection of where we really need to reflect, but also to develop new skills and really develop the capacity and the capability to kind of reroute our biases and reprogram ourselves with new information, new experiences, new knowledge. And then just getting comfortable with being uncomfortable. We know that racial bias has definitely led us to ongoing health inequities. And I'll just call your attention to this last green bullet, because I think it's most current, but it's also, I think, most appropriate in terms of this audience. Racism is a core social determinant of health that is a driver of health inequities. These health inequities are not the result of individual behavior choices or genetic predisposition, but are caused by economic, political, and social conditions, including racism. So we know that, especially as we think about kiddos who might have experienced adverse childhood events, who are now aging individuals, we know that there's long-term effect of social determinants, including racism, that have created inequities. We also know that those systems that our hospitals are wired on, as well as our insurance payers and all of those different systems, are grounded in exclusionary practices. And so we really have to, in some cases, closely examine those, and in other cases, blow those systems up and rebuild them. And that can be really hard to consider, but there's sometimes small steps that we can take to do that. One of which is through institutional accountability measures. And those can be small or big in multiple different ways. At the kind of personal level, for example, when you see social injustice, or when you see micro messages happening from a provider to a patient, how do you help stand up on behalf of patients and families, getting involved and speaking up instead of remaining silent? Those are small ways that you can interrupt those systems and rewire those institutional biases that can exist. Altering the power hierarchies. I think that physician in the video that we just watched really explored this carefully as she talked through kind of like, really trying to understand what the patient believes is wrong with them, what symptoms they're experiencing, let's say they want to quit smoking, what tangible goals can they set, informed by best practice that the physician might share with them. But that kind of centering the patient approach really helps to engage patients, amplify their voice, and in many cases, get the patient's buy-in in the treatment and care plan, as opposed to just having it be imposed by the provider or the system. And then developing mutually beneficial partnerships, whether it's with a patient-provider plan of care or whether it's with the community. So, for example, maybe you're doing some kind of community health initiative or screening event. How do you co-develop and build the strategies together, as opposed to having the big hospital on the hill come in and tell this community this is what they need to get better, right? So these are just some strategies to think about. I think sometimes as care providers, and sometimes we may be of the hospital or of the health plan or of the system, but sometimes we might be just an intermediary. It can be challenging for us to kind of reconcile some of the challenges. So I just pose some of these questions and would invite you to throw out your answers in the Q&A box or in the chat. And thanks, Martha Shapiro, for your observation about the empathy video. I think it's always really good grounding just to be reminded of our why. So just look at these questions for a moment and then just type in some observations, some thoughts. How do we better understand the populations we serve? And maybe how do we engage them in collaboration and not just impose our treatment plan on them? How do we get our funders, right? Whether it's health plans or philanthropy to engage in this kind of collaboration? So any thoughts from the audience? This webinar format is very challenging, but we'll see. Let's see, there's maybe one Q&A. Thank you.
Yeah.
Staying curious, client-centered approach versus a therapist-centered. Absolutely. Thank you so much, Jesus, for your feedback. Client-centered approach is really, to me, a very impactful centering process that I typically try and do before any encounter, just to make sure that to be reminded that it's not about me and my goals. It's really about the client or the patient, or in my case, the student, whatever it is they're wanting to take away. Moira comments that she educates providers all the time about the importance of Medi-Cal in our environment to bring health equity. It can be a challenge, definitely. And sometimes, really hard to change those huge systems that can be just gigantic machinery. But I feel like sometimes we avoid it completely, but little small things can really have a huge impact. So there's just some really great comments in the Q&A. Our organization has done focus groups with clients in order to get feedback on what we can improve and what we're doing well. That's fantastic. And I hope that it's in a multilingual format so that you can hear from different voices in your community. I understand populations we serve by asking questions and doing research, doing assessments and treatment plans, staying curious, asking permission, requesting feedback, and encouraging full participation. Those are great ideas. Thank you guys so much for your thoughts. I really appreciate the engagement by the collective. I think we always take away nuggets and apply them to our own practice. All right, so before we transition to our quick kind of cross-cultural communication model, that if I was that physician that was delivering care in that previous video, this is kind of my interpretation of her approach. So before we jump into this quick model, are there any other questions? Let me see, we've just got some additional commentary, I think, but no questions at this time. Great. Well, we will make sure to hold time at the end to make sure we have time for questions. This is a very quick overview. This is not an in-depth exploration by any means, but it's a 5-step model that I have kind of carried with me for the last 20 years. It really helps me kind of stay grounded in some of the key things that were discussed in the Q&A or the chat, really taking stock of kind of like, how do we make this a patient-centered approach or a client-centered approach? How do we really better understand our own blind spots and our own biases that we might bring to those encounters? And then how do we navigate through difficult conversations and really hopefully get to really meaningful communication that has an end goal with exceptional patient or client outcomes, right? So this is a very quick 5-step model. We're not going to spend a huge amount of time unpacking all of these because we've kind of talked about some of these baked into the previous segment on cultural humility. But we'll just walk through these kind of 5 slides, and then we'll explore very quickly a case scenario, and then kind of apply some of these steps with a case. So again, I don't want to beat a dead horse, but really step one is really having a better understanding of yourself, really questioning your own assumptions and biases. Where did your own cultural framework or cultural programming come from? Where did your values come from? And really challenging yourself to understand how you might use your values to normalize others' behavior or style or communication or decisions. And so really being able to pause and reflect when you recognize that you're doing those things, but also at the same time increasing your awareness of others. So thinking about from a patient perspective and reflecting on that empathy video that we started out with, really trying to pretend to walk in the client's shoes, learning as much as you can about their cultural values and norms and where they came from, finding out the reasons for those values, and becoming aware of how other groups are affected by being seen as different. And that can be, through exploration with different cultural groups, through having what I would call key informant interviews or conversations with different colleagues or partners, where you really explore that and begin to develop muscle around how we welcome and receive clients and or colleagues who may be different than we are. That acknowledgement piece is really critical. I use this diagram just as a simple kind of demonstration that culture and identity is really complex. It's not simple. And if I was more talented in the tech side of things, this would be moving parts all going in different directions, but I'm limited in my technology. But at the core, we have our personalities, we have our internal dimensions of diversity and our external dimensions like marital status, parental status, work background, educational experience. And then lastly, our organizational dimensions, right? So all of these different moving parts impact our communication and encounter with our client or patient. And just the simple process of acknowledging our differences in some simple way can really be helpful in level setting and, I would say, normalizing or flattening that power differential. You can do some really amazing acknowledgement just by effective listening. And this is just a few examples of different types of listening you might employ when you are engaged with a client or a patient, or even with a colleague or peer, or maybe one of your team members. Lastly, affirmative listening is probably one of my favorites, but sometimes can be really hard to do at work. Hopefully not with your clients as much, but sometimes it can be really challenging to do affirmative listening with a peer or colleague in a meaningful way. But sometimes I think can be really validating. Which moves us to our next step. The listening slide kind of transitions us from acknowledgement to validation as a step. This is really a really important piece of the process. And I think that physician who in the previous video talked about ways in which she acknowledged and validated her patients by the way she did her history and physical, or the way she talked about goal setting, or discussing choices and options that patients have. Because sometimes it can be very easy for patients to really hear only one option, right? And it's the preferred option from the physician. I want you to quit smoking completely cold turkey, right? And that may just not be a reasonable, feasible option for you right now. So just really trying to validate, acknowledge where people are, and really trying to minimize the power differentials. And I'm just going to ad lib a little moment here, especially patients and families that might be foreign born or who come from abroad and are maybe refugees or immigrants here in the US, challenging a physician can be really difficult. In fact, probably taboo for many communities. And so sometimes we as the provider might need to do that level setting gently and carefully, because we might run the risk of losing trust from our patient if we don't navigate that correctly. And sometimes, I'll just add, it can take a little trial and error. Some patients and clients might need a little more, a little less validation. Negotiation, I think, is a really important piece that physician talked about in their segment about how do we get to a shared goal together in collaboration, and not just me imposing upon you my treatment plan for you, but also you as the patient or client making a commitment to kind of meet in the middle. And so this kind of concept allows us to reframe and develop options that we might consider. What does it really mean to negotiate with a patient or a client? I know that when I wanted to quit smoking and my doctor wanted me to try medication, that just wasn't an option I wanted to explore. I wanted to explore harm reduction as a first step, going from 20 cigarettes a day to 5 a day, right? So that kind of negotiation can be really meaningful in not only the long-term relationship, but kind of also thinking about things from a systems perspective. And then the last step in the model is really about action. How do we think about choices and options and reaching an agreement with patients and or clients on next steps, right? And how do we hold accountable in a gentle way, and then respect families' choices without judgment. I'll just keep on with the smoking cessation example. My doctor, I knew, really wanted me to stop smoking. I really wanted to reduce smoking toward the goal of stopping smoking, but we weren't on the same page. But I felt that they respected my decision and did so without judgment and allowed me the leeway to work my plan. But they held me accountable, which I really appreciated. So that kind of, action and choices, we all employ those quite differently as we assess each patient or client's needs. And so what I would invite us to do is kind of think about a few other considerations, and then we're going to walk through a quick case. It's 49 after, so we've got a little bit of time, and we won't go into a lot of huge depth, but we'll try and look at a case and then apply each of those steps. And then hopefully you can remember those steps next time you have a cultural impasse or a communication challenge that you're not sure how to navigate. You can maybe try this out and see how it works. Some other considerations when you're thinking about providing care to diverse patients and collaborating with colleagues is to be mindful of social determinants that are going to be possibly impacting patients' decision-making, right? So thinking about housing and food security, right? If I have a medication that costs $200 that I can't afford, and I have a light bill that costs $200, I might have to be making some of those difficult decisions. Some other things to consider: sexual orientation and gender identity, right? Maybe we're not aware of something the patient might be experiencing, challenges or bullying or other kinds of harm related to their sexual orientation or gender identity. Being mindful, paying attention to preferred name and pronouns. Thinking about food and diet as another scenario. I'll just give you a quick example. We had a large Hispanic diabetes clinic, and our nutritionist wasn't having great success communicating effectively with our families about diet and portion control and carbs and proteins and all of those things that we know lead to healthy, nutritious food intake for a diabetic patient. She worked in collaboration with a community health worker and interpreter to look at culturally appropriate foods, and developed a diabetes manual that that was more responsive to the foods that families were more used to, and provided some various options to explore. So it was a really, I think, innovative approach. So those are just some things you might need to pay closer attention to when you're thinking about employing this model. The last one is really important, I think, especially in cross-cultural communication, especially in working with refugees and immigrants. Sometimes our communication approach, our communication style in the US is very direct, to the point. It's evidence-based. It's, very straightforward and direct, and can often be misunderstood and misinterpreted as rude, offensive by other communities. So just be on the lookout for those kinds of signals when you're approaching or communicating with someone who may be an indirect communicator. You might have to adapt your style and approach a little bit. All right, so if you're like me, you forgot the 5 steps already, but here is just a refresher of the 5 steps. And we're going to quickly just read through this case scenario together and then answer a few questions using the 5 steps. So a nurse practitioner is giving very complicated instructions on a medication regimen to an adult patient. The patient emigrated from rural Mexico about 4 years. Patient speaks very little English or Spanish. Their primary language is Mixteco. The nurse opts to use the telephone interpreter since it can be opts not to use the telephone interpreter because it can be difficult to find the code. She makes the assumption, because the patient's smiling and agreeing with everything, that she understands the complicated medication instructions. When the patient returns the following week, the nurse discovers the patient's status has not changed and there are remaining medication tablets. To better understand the patient, she finally opts to use the telephone interpreter and discovers that the patient had not been taking the prescription as instructed. So this is a case scenario. Although it's quite medical, I think we can apply it to various different scenarios kind of from a psychosocial perspective. So let's apply the 5 steps, right? So why might the nurse believe the patient understood the instructions? So just do a quick, what do they call that? A chat waterfall, and just tell me why the nurse might believe that. Anybody?
We'll make that a Q&A waterfall, but
Q&A waterfall. Thank you so much. And I'm gonna just get us started with this first question in honor of time. So, right when there is maybe a miscommunication or discordance in language, and someone smiles and agrees, there's an assumption that the message is received. And the patient might just be trying to be respectful and not disobedient, or if you will, or not compliant. So why might the patient affirm the instructions even if they don't understand, right? So they're trying to be the best patient that they can be, and just acknowledging and accepting, yep, I got it, as if in agreement. Thank you, Maura, for chiming in on there. So what about step 2? How can we acknowledge this challenge in a positive way? In what way did the nurse not acknowledge the patient? So someone type in, how did the nurse not effectively acknowledge the patient? I promise there's not a quiz at the end. The nurse should have had a translator, right? Exactly. How difficult can it be to find the right code? And just kind of, again, from that empathy mindset, would we tolerate that if we were abroad and we needed to access a healthcare provider? Would we have expectations of an interpreter? Absolutely, yes, we would. And so I think that sometimes when we don't put that effort in, we are dismissing the patient. How could she have acknowledged the patient to ensure great care, right? She could have taken the time to find the code. She could have maybe even just borrowed someone to try and verify. This is complicated by even more complexity in that it's a fairly rare language, or at least it is in the Midwest. Maybe not so much in California, but to find a Mixteco interpreter here, like live, is virtually impossible. So we really have an obligation to ensure that language access. Step 3, honest validation. Thank you, Yingli, for your comments in the chat. How can we validate the patient? What does honest validation look like in this scenario? And I think to Yingli's point, she might have been commenting on the acknowledgement and validation. Just by us taking the time to secure the right resources for this patient shows the patient that they're important, and whatever illness they have is important, and that we value their time and we care for them. That is validation. What about negotiation? How can we, what would be the shared preferred outcomes of this scenario, right? We don't even know, because initially the patient doesn't even understand what's wrong and how to take the medication correctly. So it's really hard to negotiate. Most likely, once the nurse practitioner finally got the interpreter on the line, they were able to really unpack the medication regimen, maybe utilize some health literacy strategies like teach back to ensure that this next round of meds, that you have the patient teach it back to you, so you feel confident that they know exactly how to take the meds and when. And so that can really be our action step, using those kinds of strategies. So because of time, I would encourage you to take the time to kind of use this framework and apply it to other case scenarios. I'm going to share with you some resources. We'll come back to questions here in a moment. This implicit bias resource guide has an amazing set of case scenarios, similar to the one that I just shared with you, that you might be able to use maybe at a staff meeting or with your students. If you're a preceptor or supervising social work students, you can take those scenarios and apply this model. We will be sending you the slide deck after today so that you can have it as a reference of the model. Here's some additional tools that you might consider improving cross-cultural communication at work. These two links are very valuable. And then this last article is really about how do you rewire your own bias to have a more productive conversation. And then lastly, we want to just remind you that there's another session coming up December 8th from 12 to 1 Pacific time. And you can go to the GSWEC website and you can register there if you want to join us for understanding the dynamics of difference. And there is a link in your chat. And then we can just save this last few minutes for any questions the audience might have. Thanks so much for joining us today. And I'll just put up my contact information in case you have a question, you want to bounce it to me. I'm happy to receive that. Or if you have a question, just pop it in the Q&A box today.